I am Danguolė Jankauskienė, and I am a professor of Mykolas Riomeris University, one of the founders of Health Forum in Lithuania, which is the platform for discussion. And we have some colleagues together with me, Katrin Fjeldsted, and she is president of European Doctors Association, standing committee. Juozas Pundzius is our chairman of National Health Board in Lithuania, and also Marina Karanikolos, she is a research fellow at European Observatory for Health. Talking about health as a human capital, I would like to invite you to think not only about the human resources that we have in health care, but I would like to think a little bit in a broader perspective as human resources as creators of our national health product and our wealth and also economy of our countries. Because healthy people, they are productive and they create GDP. Unhealthy people need more resources and more expenditures. So we in health care sector also have to be, we should have more broader thinking about how we can make those people more healthy, not only how to treat sick people. In order to do that, we have to know what are the cost-effective health promotion and disease prevention instruments. And also we have to care about our own professionals who are working in our system, and they have to be healthy too. Health is, and social sector is one of the biggest employers in the world. It is expected that till 2020, there will be the jobs till 8 million of jobs that it will be created in that field. So we have to know how to plan, how to recruit, how to retain, how to train and retrain those people. So all those issues we will try to discuss in this session. And the aim of it is how those human resources can be used for our sustainability of health system. So I would like to invite Katrin Fjeldsted first to share her ideas about changing demands of health professionals and new emerging for training, for recruitment, for retention of health professionals. And then we will go further. And afterwards, maybe you can also share your experience from the audience about the challenges. For example, our countries, newcomers to European Union, will always face this immigration problem with the brain drain, and when our professionals emigrate due to free movement of professionals to other countries, and we suffer with the financial resources because of this, and other questions that you can raise. I think we will have time to discuss. So Katrin, floor is yours now.
Hello everybody. My name is Katrin Fjeldsted and I'm president of European Doctors, as has been said, but I'm also a GP from Reykjavik, Iceland. And I want to start by saying, because you're mentioning, Danguolė was mentioning health professionals. I have for a long time had the problem with these words, because I always thought of it on one side as the medical profession and then allied or other health professionals, but this is apparently not the correct wording today. So now we are all anonymous health workers. But there we are. So I want to start by telling you a little bit about what CPME is doing. It's an old name, the Standing Committee of European Doctors. It's a bit archaic, but it's CPME, which is a French abbreviation, and we have members that are national medical associations across Europe. And at the moment, we have about 32 members, associated members, and observers. Now, the best possible quality of health and access to health care is a main issue for us, and we think that should be a reality for everybody in Europe. And to achieve this, we try to promote the highest level of medical training and practice, the safe mobility of doctors and patients, lawful and supportive working conditions for doctors, and the provision of evidence-based, ethical, and equitable healthcare services. And as can be understood, we are committed to contribute the medical profession's point of view to the EU and to European policy making through both proactive cooperation on a wide range of health and healthcare related issues, and also by participating as required from those institutions. And we strongly advocate a health in all policies approach on the determinants of health to prevent disease and promote good health across society. Our activities cover a range of topics, as can be understood, because the EU and the Commission deal with a lot of things related to health, although health is mainly the issue of member states of the EU. These areas like professional practice, pharmaceutical policy, public health, patient safety, quality of care, ethics, e-health, these are all very important policy areas. And others that we are currently active in are like health inequalities. We hosted a conference with the Medical Organization of Ireland in Dublin in April under the name, under that title, Combating Health Inequalities. We're also involved in active and healthy aging, and as such are members of the and participants in the European Innovation Partnership on Active and Healthy Aging. So apart from developing policies in response to EU developments, we also have own initiative policies. I remember the first one that I got involved in the CPME about well over 10 years ago was to try and get the CPME to agree to a policy to be sent to the Olympic Committee to ban hitting above the neck in Olympic boxing. That was quite an amusing but still serious task to take on. It did not make any difference to Olympic boxing, though. As set out in our mission statement, we believe that high-quality medical training and professional practice is key to high-quality healthcare. Therefore, we are involved in a number of activities in this area. We were active in the revision process towards a new professional qualifications directive. This law sets out a framework for the recognition of doctors' professional qualifications in a member state other than the one in which they graduated. It sets out provisions relating, for instance, to the minimum duration of medical training, the verification of doctors' language skills, and the issuance of alerts when a doctor loses a license to practice. A lot of time and energy has been put into dealing with the way we as professionals cross border to work in another member state. And there is now at least less than 4% of patients that seek cross-border treatment. So it's an interesting number. It's less than 4%, may be even as low as 3%. So obviously the bulk of the work is within each member state, as it should be. Now we are also involved in the implementation of the Commission's action plan for the EU health workforce, which was adopted as part of the European Commission's communication for a job-rich recovery in Europe. In particular, we are a partner in the joint action on health workforce planning and forecasting, which hopes to contribute to gaining a better understanding of the future needs related to the health workforce, and to promote cooperation between member states to improve the sustainability of their healthcare systems. A second activity concerns a study reviewing and mapping CPD, which is continuous professional development, for doctors, for nurses, pharmacists, dentists and midwives in Europe. And CPME is currently leading a consortium which started this autumn, and we will carry out this study in partnership with the mentioned professions. Now, medical practice is in a changing environment, and we know that. And that's a question of policies and the realities in our societies. And a few points I want to mention are the evolving medical training and practice, health technologies, healthcare systems, the role of the patient, and the regulation of the profession. So if I start with the medical training and practice, medical training, its organization and content are to a large extent a competence of member states, and therefore embedded in national policy frameworks. But there are several developments relating to the European legal framework. And I want to mention three. The Professional Qualifications Directive that I mentioned earlier, that has been revised. It's from 2005 and is currently awaiting formal adoption by the European institutions. Since doctors, along with several other healthcare professions, are subject to the special rule of automatic recognition, the directive stipulates the minimum duration of both basic and specialist medical training. For basic medical training, the new minimum duration is 5 years or 5,500 hours. CPME supported a clarification in this, but was very much in favor of ensuring that there is in no way a watering down of the training requirements. Because we know as doctors that the more you learn, the more you know how little you know. And that goes for medicine, definitely. For specialist medical training, there were no significant changes made. However, independent from the revision of the directive, our member associations have reported on governmental plans in some countries to decrease the duration of specialist medical training to the minimum requirement, and this has to be followed. As I mentioned earlier, CPD, or continuous professional development, seems to be gaining recognition in the EU policy context. CPME has long believed it's a fundamental ethical obligation for doctors to ensure their knowledge and skills are based on up-to-date scientific evidence. And this is, of course, based on our Hippocratic Oath. This includes, there are some developments at policy level within the EU to support CPD. This includes a reinforced provision in the revised Professional Qualifications Directive, which encourages member states to put in place CPD programs for healthcare professionals. In my country, it is on our contract that we have 15 days of study leave with full pay. But I believe that one of the stringent measurements brought on in Lithuania is to remove those study days with pay from doctors. And that is quite a serious situation if you want to retain your knowledge. So I think I'm right in saying this. Maybe with the understanding that doctors are so dedicated to their patients that they will accept any measure. But in the end, of course, it leads to burnout and leaving the country for better conditions. So it's not a very viable measure to take. Alongside qualifications, medical practice is of course greatly affected by actual working conditions for doctors. While there are innumerable factors which influence these conditions, including staffing ratios, pay, of course, or contract formats, to name but a few, like the one about study leave. One of the most significant EU-level factors is the European Working Time Directive from 2003. And this directive is to ensure safe working hours for doctors and therefore patient safety. Its implementation in many member states falls short of this objective. And in many of our countries, including my country, which is Iceland, the pay has been cut and the number of hours sometimes extended. So that's not really in line with the European Working Time Directive. This results in working conditions which not only harm doctors and patients in the current system, but also influences recruitment of doctors to get new doctors to train, and retention of doctors to stop doctors leaving or retiring earlier than they would otherwise. And CPME has repeatedly stated that the protection of workers' health and safety must be the primary aim of the legislation. Apart from factors, talking about technologies, apart from factors which affect the framework of medical practice, the everyday tools doctors use are also evolving. The rapid developments in health technology contribute significantly to the changing environment of the way we work. We have continuously underlined the need to ensure that all innovation is driven by the objective to improve quality of care. So new health technologies must be assessed as to the value-added patient care, not technological progress or economic benefit. Now, development in pharmaceutical care. I want to mention new generic medication or biosimilars that are entering the market, but all has to be thought of with the best outcome possible for the individual patient. Telemedicine, e-health technologies have changed the clinical decision-making process. I'll try to shorten my talk here to give others a chance to speak also. But we think that safeguarding the trust and confidentiality of the patient-doctor relationship, regardless of the medium through which healthcare is delivered, is of core importance. The principle of confidentiality must be applied to the entire framework of data protection legislation. And into that comes the legislative framework on medical devices that we were involved in, and I won't go into that. And then the evolving healthcare systems, of course, they have been discussed quite a lot today. the change from the 1930s hospital-based healthcare system to what is now discussed, to my great joy as a GP, to primary care community-based services. I have a feeling we GPs have been saying this for about 30 years, but it was sort of thought to be in our own personal interest, which it wasn't. It was policy and vision, I think. And this is now high on the list, and I'm really glad about that. And the organization and training of the health workforce is under constant change in all member states. And often these changes are driven by financial pressure. But I must say that for doctors whose training is maybe 10, 12, 15 years in all with specialization, and it's not surprising that doctors want to have a say in the way their work is structured and run. The process for clinical decision making is often affected by these measures, and one example is task shifting. But as was said earlier today, it was Martin Seychelles, actually, from the Commission, who said cardiologists cannot be replaced by nurses. Well, I want to add, neither can GPs. They cannot be replaced by nurses. And in the same way, nurses cannot be replaced by doctors. So I think there is obviously a possibility for task shifting, but it has to be done from those who have the task to others who take it over without necessarily taking the responsibility for the task. Now, in the US and in the UK, there is now a new profession called physician's assistants, who have some basic training, whether it's a year or two, and they are actually trained to work with doctors and be their right hand or the left hand, for that matter. And that's a very interesting development, which surely will come to the rest of our countries before we know. Now, we on task shifting, we have a policy, of course. It's from 2010, and it says, and I quote, "In order to guarantee the safety of patients, task shifting should always take place under the condition that the responsibility for diagnosis and therapeutic decisions cannot be divided and remains with the doctor, even if she or he has shifted a task as described above," and I unquote. Now, cost effectiveness, effectiveness and the patient's best interest have to be balanced. Patient mobility, I'm not going to go into this any further due to lack of time. And then we go to the patient role, and that's our view that the core of any work in the healthcare sector is the doctor-patient relationship. And that has to be a guiding objective in all our policies. And one pillar of this is patient empowerment. And that comes into the joint principles adopted by the European Patients Forum and the CPME, because we have been working quite closely together. Patient empowerment, sometimes have joked that it's not that the patient consults Dr. Google, because Dr. Google has maybe not quite the same view as the doctor who knows the patient. So we have seen the parallel developments of increased patient empowerment and health literacy, and these are big issues that we've been working with the European Patients Forum on, and it enables patients to participate more in their own conditions. And the last evolvement one is the evolving professional regulation. In many member states, reviews of regulatory approaches have challenged the self-regulation of the profession, and we think that weakening this self-regulation weakens the professional autonomy of doctors. So I will not go further into that either. So we come to the future, and that is, we think it's best ensured that guidelines are developed on professional level, and so we have opposed the European standardization or the CEN involvement in medicine because traditionally and through centuries the medical profession has been quite able to define standards for the training and running of medical practice, and we don't think there is anybody better to do it. And the CPME calls on national and EU policymakers to safeguard effective healthcare service for every patient in Europe. And I must say I agree with Monika Kosinska, who said earlier today that we do have the money. Even if you only think of the tax havens that may handle half of all the world trade, and maybe a third of all foreign investment might be in tax havens. So I think there is money around. It can be used, for instance, to secure what we are striving for. And in conclusions, as doctors, we continue to advocate the importance of investing in health and in the health workforce. We call upon the national and EU policymakers to enshrine the health in all policies approach in all political agendas, either by putting the Minister of Health in the driving seat, as was said earlier today, or for all ministers to share the responsibility for health, as was done with environment in the last decade or two. And we want to cooperate with policymakers, with politicians, and I think it is very important that the medical profession and politicians have trust in each other and can work together, because we have a lot to offer and we also need to work with the patients. Thank you very much for your attention.